this is that same patient, and we went ahead and we put this specialized sort of pacing system in him. And this is a really busy slide, but I really want you to focus on one thing here. We did ECGI on him under all of these different conditions to see if it actually worked. Condition number 1 is his best CRT setting. And remember, this is the same scale that I just showed you. Red, early and good. We expect to see lots of red and green. Blue, bad, late. And we see in condition 1, here we go, we see exactly what we were hoping for. Lots of red, lots of green. This electrical desynchrony index totally normalized to 21 milliseconds. We tested him under a lot of other conditions, and we saw the only other one that was just as good was condition 5. Magically, he happened to that day to have his own conduction system working. It just happened to be that day. And we were able to make the pace setting look remarkably similar to his underlying rhythm. This is the goal. This is what we were trying to do. Now, how did this kid do clinically? He felt better. I can tell you because I still see him. He's up, he's playing soccer, he feels great, he's growing, he's in school, and he's doing fantastically. We consider him a clinical responder. Let me walk you through another patient. This is one of our 21-year-old girls, and we all know that adolescent girls don't take their medicine. So we were a little worried that, okay, she came in saying, I feel terrible, I can't eat, I'm not going to high school. Well, you gotta go. This is why you're 21 and still in high school. So maybe we should put a device in you. We put the device in her, and she still wasn't getting any better. And we were thinking, why? Why is she one of our 20% of non-responders? And I said, well, let's see if we can learn something from doing ECGI on her. So this is what her heart looks like. Now, mind you, she's one of those patients who only has one ventricle or one pumping chamber that has to pump to the heart. So she doesn't have the 4, she really only has 3. And what we see is that under 3 different conditions, the top condition being her CRT, or what we thought should have been her best condition, and these 2 being other types of pacing conditions, they all look awful. So same scale. Red is early, blue is late, and we see these huge areas of green and then blue abutting very close to red. And again, we talked about those black lines of scar being there and can be very bad for wavefront. You can see here how this tries to break through this line of scar and just can't. It just can't. And so what we realized when we looked at this girl was, well, we're missing this whole back part of the heart. Nothing can get to it. We put the leads in the wrong place. If we'd known that before, we perhaps would have targeted our therapy better to suit her. So we actually made a decision that we were going to try to do that. But since she was so ill and on the transplant list, she got a donor. We accepted her donor, and she went on to heart transplantation. And I'm happy to say it's doing quite well. So in conclusion, ECGI may actually help to correctly identify the patients who may benefit from CRT. It may actually help us guide where those leads should be placed to make the heart the most efficient kind of pump it can be. And then finally, it might help us optimize that electrical desynchrony index in a way that will correlate, hopefully, with a good clinical response. I'd like to thank the CDI for allowing us the opportunity to have our own machine and study all these kids, because we really are learning spades of information. The Rudy Lab here at Washington University, which is part of biomedical engineering, that's the lab that we work in conjunction with to be able to do the ECGI in our patients. Within the Department of Pediatric Cardiology, Drs. Van Hare, Dr. Cantor, our nurse practitioner Tammy and Tim Sikorsky, who does all of our echocardiograms with us, and finally from cardiology, Pam Wittard and Tim Street, both of whom are in radiology. Thanks for your time, and we're welcome to go up through the demonstration up here. Please.
I was just going to ask, when you have something that's so kind of on the cutting edge like this, does insurance even acknowledge that, this is necessary?
No.
And makes a difference?
No, and in fact, this is still very much a research project. We are learning from our patients. As much as we're trying to help them, we are learning so much more from them. This is not part of the standard of clinical care. The word is sort of getting out that we can do this, so we certainly have more people coming to us saying, hey, I want one of those fancy pictures of my heart, especially when it comes to the heart failure population. But no, not yet.
Small
Yes,
of a child can
So that's a great question, actually, and one that the grad students that I work with are constantly asking me. The youngest child we did was an 18-month-old. He was challenging because 18-month-olds, when you put things on them, think it's a really great idea to take it off. And we need these leads to be in a very stable position. So we were able to do it with much difficulty. I kind of skipped the 2 3-year-olds because I think that's just not going to work. But we've also done 5-year-olds reliably and successfully.
So you can't sedate them?
That's a great question. So, and a question that I get asked a lot. I think that once we prove the utility of this in patients that I don't need to sedate, then I can make a very good argument to say the risk of sedation is worth it for you to have this test. Sedating a patient with heart failure is a bucket of trouble, and one that I'm willing to get into if I know that it's worth the cost. The more I do, the more I think it may be worth the cost, but I need to prove it to everybody else so there's no question about that. But it's a great question.
Good luck with that.
Thanks.
So now you all can come up and
Let's see what we've got up here.
We'll give you one bit of warning.
Oh,
although there's lots of
yeah.
doctors in the house, we don't want to use them. So
These leads have coils at the end that we actually screw into the heart muscle. So if you actually poke these into your finger and try to screw it in, it will screw in.
Just in case.
Forewarning.
Don't do that. He was the one that we don't use the word down.
That may hurt. So we have some leads for you to look at. We have examples of what a standard pacemaker looks like, what a standard defibrillator looks like, and then comparatively what one of these CRT devices look like. And these are these are all industry given to us, which is why you see their names all over them. But this is the relative sizes of them, and you can see them, touch them, hold them, and see how much they feel and weigh. A model of...
Size is not pediatric versus adult.
No. And in fact, none of these devices are approved for use in pediatrics. No surprise there. A model of the heart, so we can sit and talk about how things kind of get through, how things get wired in there, how we do that. And then one of our electrodes from our ECGI system, so that you can see what it looks like and see what it feels like, and see what it would feel like to have 8 of these plastered onto you.
For how long?
So to actually acquire the electrical data, that takes a minute, 2 minutes. But then you've got to get them in a wheelchair, get them over to CT scan, have them lay down, do the CT scan, and then take it all off again. We thought getting it on was hard. Taking it off is so much worse because these are really sensitive. And if you come up here and when you look, you'll see that every single one of these leads is hardwired through here. So you can't just rip it off. You've actually got to take them off one at a time. Try telling a 5-year-old that. Really hard.